Good morning, and Dr. Kim Williams, I'm Chair of Medicine here at University of Louisville, and welcome to Internal Medicine Grand Rounds. We have an interesting, I hope you'll find, conversation this morning that we're going to have with a lot of learning on primary hyperaldosteronism, teamwork, and talent to win the championship. And talking about teamwork, we are actually going to have the presentation given by three of our wonderful faculty, and we are looking forward to all that they have to teach us. But to give them the proper introduction, I'd like to introduce Dr. Sri Moksudundam, who is actually our division chief, longstanding division chief here in endocrinology. Sri, take it away.
Welcome everyone to today's Medicine Grand Rounds. I'm very happy to introduce our three speakers who will be talking about a problem that has been under-recognized and under-diagnosed for a long time, and now has grown in terms of our ability to diagnose it and manage it tremendously over the last 15 years or so. But this also requires us to have a teamwork, because this requires very close coordination between endocrinology, interventional radiology, and endocrine surgery for proper diagnosis, identification of the lesion, and surgical intervention and follow-up. So we have assembled three people who can talk to this in a very comprehensive way. So first of all, I'll introduce Dr. Javid, who is Associate Professor of Surgery and the Chief of Endocrine Surgery, Endo Chair in Endocrine Surgery at University of Louisville. She obtained her medical degree from Cambridge, England, where she also did her surgery training, did a PhD in biomedical and clinical sciences at Trinity College at the University of Oxford. She later came to the United States, where she trained in endocrine surgery at Yale, and then was for a few years at the Medical University of South Carolina before she moved to the University of Louisville in 2022. She has been well known in the field. She's also the Associate Program Director for the Surgery Residency Program, and she has a number of publications. She's worked on several committees and presented at national and international meetings. The second person that we would like to introduce is Dr. Nana Baah. He is assistant professor in the Department of Radiology, where he's director of the interventional radiology. He has been at the University of Louisville for the last 3 years.
Actually, five.
5 years.
Which was three. It had to be.
He obtained his medical degree from Virginia Commonwealth University School of Medicine, did his residency at Howard University, and fellowship in vascular and interventional radiology at the Medical College of Georgia. He has worked closely with several of the specialties, and from our perspective has been great help in working with us and developing protocols to do these kinds of procedures, which require not only just skills that are technical, but also trying to organize and make sure that all the samples are correctly collected and analyzed properly so that we can interpret those results. Finally, we have Dr. Krishnasamy, who is Professor of Medicine from our Division of Endocrinology. She's the Program Director for the Endocrinology Fellowship Program. She has been at UofL since she joined our fellowship here in 2004 and became a faculty member in 2006. She has been a star for our department, both in terms of clinical care, education, and research at UofL and also at the VA. And she took this tremendous effort to put all of these together. And so, Dr. Krishnasamy, if you can take over.
Thank you. Thank you, everyone, for being here, especially my co-speakers, Dr. Javid and Dr. Baah. Dr. Baah is also a residency program director for radiology, and I know he has to give his interviews or start his interviews pretty soon. So thank you for taking time for both of you. And Dr. Javid moved her OR today so she could be here. So thank you so much for your commitment to doing this. And we'll get started. Also wanted to, sort of offer my condolences and my prayers and thoughts with the families of the victims of just recent the UPS Airlines, because I have a close connection. My husband is part of the UPS Airlines, so it's been like a personal sort of thing. So these are my conflicts, and the objectives are, I decided to do this when Dr. Mokshiganam said, can you do the grand rounds? I said, most people here know I like doing interdisciplinary, multidisciplinary team building, whether it's here or the VA or anywhere else or with my fellows. And one of the things we worked on, just like he mentioned, early pandemic was, we identified that we had a great need for this procedure called adrenal vein sampling. We used to have someone who did it more than 10, 12 years ago, and then we didn't have anyone. And when I had to have patients who I identified, I usually had to end up sending them either to University of Michigan or Mayo Clinic or somewhere else. And so I reached out to, at that time, as we were doing things, I reached out to Dr. Contractor. I had also forwarded this to him. And he happened to identify, he said, we have a star in our department who will be a rising star. So, and I said, okay. And then I had a great fellow, Dr. Sibai, who is now left from here and moved to Chicago. So he was in his first year, and around Christmas time is when we did the first one, the day after Christmas. I still remember we were sitting on our phones and looking at samples, and also the lab group, Dr. Jotani, I believe he must be online. He was immense help, and of course, all our endocrine surgeons, and Dr. Javid also establishing the endocrine tumor board. So we have done a lot of things these last 5 years in this area and others. So I will describe a case first, and then we'll go from there. And this case patient was referred to me by Dr. Rangaswamy, one of our community medical group cardiologists from UofL South. And this lady is 34 years and resistant hypertension, preeclampsia, eclampsia, and also BMI over 45, obstructive sleep apnea, type 2 diabetes, atrial fibrillation, HFpEF, MASL, GERD. Sounds familiar to all of us, correct? So, and this is a medication list. Potassium, mineralocorticoid receptor antagonist, 100 milligrams, hydrochlorothiazide, Bumex, clonidine, which is an alpha central blocker, and lisinopril, metoprolol, hydralazine. Potassium, she was at 40 BID milliequivalents. In spite of that, her levels kept going low, so we had to actually increase it to 60 BID. And because of the new onset AFib, she's also on other drugs. In spite of all this, her blood pressure still stayed high. And because of the AFib and other things, somehow he had done a workup, Dr. Rangaswamy, and he had noted that there was an incidentaloма adrenal, which Dr. Baah is going to show us more details about the phenotype of the imaging. And also he decided, because she's uncontrolled hypertension, and he did an aldosterone, metanephrines and cortisol and aldosterone renin. And I had put in here, I circled the actual assay, because liquid chromatography mass spec, it's very important to know what your assays are. That is also one of the teaching points here. Knowing our labs and knowing the assay. And he did the plasma renin activity, 0.27. These are both from Quest. And the ratio of the aldo renin was 100. And you can see the trend of the potassium here. And he referred the patient to me and said, can you please evaluate this patient further? And we were happy to do that. And I discussed with him, we weaned off the diuretics gently and started her on SGLT2 and maximized her potassium replenishment. And we discussed further in the endocrine tumor board, which happened second and fourth Thursday. And we discussed several patients there. So I would stop here so that Dr. Baah will explain later and just go into the evaluation of or talk about a bit about the new guidelines. Before I go to our guidelines for hyperaldosteronism, I would take a minute to talk about the new AHA recommendations as early this year about hypertension. And I know Dr. Williams' favorite topic is this. And when I spoke about this 4 years ago in our own group, in our grand rounds, we had different guidelines, and the change this year, right within a few months after the AHA guidelines came about, the cutoff for hypertension diagnosis, which is used to be stage 1 used to be 140/80, and now it's 130/80. Right, Dr. Williams?
That's exactly right.
Yes. So, and as we can see the list of complications here, and after 3 to 6 months of evaluation, the next recommendation is to go on and get started on medications, apart from lifestyle and dietary approaches, sodium restriction, and plant-based diet, and so many other different interventions. So in the background of that is and I also learned about the PREVENT equation. I'm only familiar with ASCVD and my fatty liver equation, which is the NAFL, but the PREVENT is something I'm learning to do now. So a little bit about aldosterone. When animals or fish or in water, they don't need aldosterone. But when evolution happened and mammalians started happening, amphibians, that's when aldo is needed in land to survive. And a great example is the lungfish or the salamander fish, which first synthesized in the sort of the eugenics of things, where the first description is from the salamander fish, because you need sodium to survive on land and protect the intravascular volume and osmolality. You need aldosterone. And also the emergence of these very interesting the mineralocorticoid receptor and the 11-beta hydroxysteroid dehydrogenase, which we call as 11-beta HSD2, which functions as a gatekeeper. So it's very interesting, that article from the 1980s talking about this. And when I talk about hyperaldosteronism, I have to mention about Dr. Khan. Everybody here has heard this name from University of Michigan, and he explained so many other areas also that he was involved in regarding the HPA axis, heat acclimatization, spontaneous hypoglycemia, and also about diabetes. And he was the first one to describe, and we all know about Conn syndrome. And so the description of primary hyperaldo, because we see these ratios and numbers all the time. What is the most important thing is it's dysregulated aldosterone production despite renin-angiotensin 2 suppression, which I'll show in a minute. And either it could be unilateral or bilateral. It could be adrenal nodule with excess production, and it could be acquired over years, or it could be genetic or familial. And there are some very interesting genes involved that have been described. And in spite of volume expansion, renin still stays suppressed. And there's an inadequate rise of renin in response to all the stimuli, such as posture change, volume contraction with diuresis, or other dietary restriction, which it does work to some extent, but not so much. And what happens in normal renin aldosterone, the normal sort of routine, what happens is that when there's hypovolemia, here, right here, and the Ang2, which is angiotensin II, renin levels go up, and the sodium absorption and from the PCT, proximal convoluted tubule, and also the distal, and also the principal cells. There's through the sodium channel pathways, epithelial sodium channel pathways, which also play a big role in therapy, along with renin-mediated sort of absorption of the distal sodium delivery. So there is more absorption into the system, and also independently, ACTH also has some effects on aldosterone. So together they cause aldosterone secretion and expansion. But once the volume is down, then automatically things do get better. However, in pathophysiologic aspects, which is autonomous aldosterone secretion, the suppressed renin and suppressed Ang2 do not give the feedback. And what happens is that there is continuous sodium absorption, both from the proximal, from loop of Henle, and there's distal sodium reabsorption through the epithelial channels. This is the MR, mineralocorticoid receptor, with no feedback at all. And the two genes that have been described are the CAC-NAID and the KCJN5, which we get it all the time in the boards. And this can cause more problems, complications, which most of us know here. And in a way, this is an interdisciplinary sort of disease, because primary care, cardiology, nephrology, endocrinology, interventional radiology, endocrine surgeon, lab medicine, pharmacists, everybody is involved in the care of this. And this is just a clip I took from the Primary Aldosterone Foundation. And the prevalence used to be described as 1% long time ago when Dr. Kahn described it, and after that. Moving on further, in 2018, 2019, Annals had some very nice papers looking at the prevalence in stage 1, 2, 3 hypertension. And interestingly, most recently, B.Chr and colleagues looked at prevalence in a primary care group of 1,800 patients. And as you can see, in stage 1 itself, the prevalence was as high as 3%, stage 3 as high as 12 to 15%. Some have described prevalence in tertiary centers as high as 30, and this Annals article looks at 11 to 22%. So higher prevalence calls for relook at guidelines in the way you screen. In the past, we screened these patients only when they're resistant hypertension on multiple medications, where there was no control, and then they were referred to a specialist, and then they were screened. Although my colleagues here in primary care have already done most of the workup when they're sent to me, which I'm very proud of. So, and like I mentioned earlier, the prevalence has increased 6% on an average. And in that 6%, many of them, 27% could be aldosterone producing adenoma. And the complications, left ventricular hypertrophy, heart failure, both HFrEF and HFpEF, microalbuminuria, cardiovascular events, end-stage kidney disease. Many times I've had young patients whom I've seen with going into dialysis on this. It's a pretty powerful disease. And for my hepatology colleagues, this can also has a direct link with MASLD, which is NAFLD previously, through the MR receptor in the liver, which activates the TGF-beta pathway and the NFK-beta, causing liver fibrosis and triggering the inflammation pathway. So it has a variety of things. So the new recommendation as of 2025 is screen everybody who is diagnosed with hypertension, not just the resistant hypertension, not just 3 meds. Every single person you diagnose hypertension, then you screen them for aldosterone. So what do we do here? So we go ahead and I'll move on a little bit faster because I know I have 2 other speakers. Oh, thank you. So the preparation for screening, because screening is always done in the primary care setting or by cardiology or nephrology, is you want to have a potassium of 4.4. And this patient, we did struggle getting there. We had to do, I've had patients as high as 120 to 140 milliequivalents that they needed. So, and we also tell them liberalize sodium. In fact, in Mayo, they do things a little different because patients fly in and they're there for a short time. So there's no time to go back and forth. We liberalize sodium there and also review all the medications, which we will go into it in the next couple of slides, because many medications such as birth control pills, because we have many young patients with hypertension, and also using other hormones can interfere with some of the assays. So it's very important we make the right diagnosis. So many times I have repeated it at least 2 or 3 times. Endocrine is all about a lot of very good lab evaluations in the right time, and our lab colleagues in clinical chemistry are our best friends, apart from other friends. So, and age, gender, time of the day, they all make a major impact. This is not something you do as soon as you wake up and come in. You make sure it's ambulatory, and also like I mentioned earlier, birth control, luteal phase of the cycle, so many different things can be affecting this. And also, there are certain medications such as beta blockers can lower renin, the clonidine, which this patient was also on, NSAIDs, then combined birth control, which birth control is a big issue for many of our assays, even for cortisol, because it elevates your binding globulin, so it increases or spuriously increases the levels. And those drugs that raise renin, spironolactone being the first one, but there was a clue there in that patient who was on spironolactone. And also the ENAS inhibitors, which is the epithelial sodium channel inhibitors like amiloride, triamterene, and ARBs, ACE, SGLT2, and a few other drugs. Dosperidone is a well-used birth control, which can also cause issues with in interpretation of the assay. And those that lower aldosterone would be ARBs and ACE inhibitors, beta blockers, centrally, again, clonidine and alpha-interleupa, and diuretics, MRAs, which is spironolactone again, birth controls, and drospiridone can also raise aldosterone. So just knowing all this in the background. And so many times we do it once, we look at the medications, then we bring the patient back, withdraw certain drugs, add certain drugs. And I'll tell you what drugs are good to use when you're weaning off. And many times, if it's pretty severe, like this patient that we just saw and evaluated, we do not. There's a danger when you try withdrawing all the drugs. So we actually discuss with primary or cardiology, the referring physician, and we make a decision of, okay, we're going to leave those drugs on and maybe just remove these. If it's pretty severe and it's very obvious, there's no need to stop all the drugs. It may actually negatively impact the patient's health. The ones that are easy to use would be your alpha blockers, which most of us, don't prefer to use, but in this case, it really works well. Hydralazine, use that a lot. And the verapamil also is the other one that we use. So once it's been decided and it's been done, the sort of switching of medicines and the ratio and everything, I want to talk about the assay. I hope audience can see this well. There are 2 different ones. We use Quest Lab on site. We set it up almost 17, 18 years ago, mainly because sometimes it was harder for patients with billing issues with the hospital-based labs, which I know has changed now. And Quest Lab has the assay that is the LCMS, which is my favorite assay. I don't know if Dr. Winters is online, but he taught me a lot, and Dr. Mokshiganam about assays and endocrinology. So, and plasma renin, my preferred is the PRA, which is what we all use here. And the cutoffs are very different. That's very important to know your lab, your assays, what is their normal, and what are the ratios, wherever you practice. So the aldosterone to renin ratios, as you can see, if it's a direct renin concentration versus plasma renin, if it's aldo immunoassay versus LCMS, by the way, immunoassays have some limitations in terms of There's sandwich assay, there's antigen-mediated assay, there's ELISA, and there's radioimmunoassay. And remember, immunoassays are the ones sometimes use biotin platform, although it doesn't sort of really impact our assessment here, but biotin is something, a big no-no. It interferes with a lot of enzyme hormone evaluations. So usually you want to tell the patient hold for 3 days. And also knowing that and then knowing the ratio. So if I see a patient with the LCMS assay and they're already very high on the aldosterone and the renin is very low, I'm not going to go change all their medications. Especially, I don't want to get them into a hypertensive crisis. But if it's very well controlled, 1 or 2 medicines, and one of the medicines is MRA, then I'm going to go ahead and change it. So that is important to remember. So, confirmatory tests. Once the diagnosis is, the ratios are set and your ratios are high enough, as I mentioned there, then goes to your confirmatory tests. If it's in this patient that I just described, we didn't need a confirmatory test. We directly called Dr. Baah and said, okay, I need a sampling here. We could skip a step. But there are some mild cases where the ratio is high, but it's not as impressive and it's not as clear. And it's not Conn syndrome, which is a patient younger than 35 and who has adenoma, distinct adenoma, unilateral, younger than 35, the right ratio, uncontrolled hypertension, no questions asked, nothing is required. Give a call to Dr. Javid and send the patient to surgery. However, this patient, even though was diagnosed earlier, by the time we saw her, she was in her late 30s. So if the aldosterone is over 20, there's spontaneous hypokalemia, no need for further evaluation. And you can directly send them to sampling and they can go on. However, if they're not, then we need some suppression testing or confirmatory. Here we use the saline suppression, which is convenient for us. When we had an RN with us, we used to do it in the office. Now we sometimes send downstairs to the infusion center. Now they moved upstairs. And these are the sensitivity specificity. Captopril challenge test I have not used, but many patients are already on a ACE or R, so there's no need to do a challenge test. The oral salt loading is what places like Mayo use because they load them up with salt more than 6 grams. So eat everything good in sodium, and then the 24-hour urine aldo collection is done. So those are your confirmatory tests. Once it's aldosterone suppression is done, and then you do repeat the labs, the ratios are right, then the next person to call is Dr. Baah. And at this point, we also sometimes do imaging. And this is where I need to put out this quote because it's very important with the work we do here. And sorry, I added the World Cup cricket because I grew up watching cricket, but I did add football also here. So Dr. Baah, take it away.
Well,
Thank you.
Thank you so much. Well, good morning, everybody. Pleasure to be here. And before I even go on further, I have to just embarrass you a little bit. You know, you and Dr. Javid, you know, you're talking about how 5 years ago, post-Christmas, we're starting to get this project off and make it well established. And I mean, all the hoops that we had to jump through, the countless hours that you put in, you know, this would not be successful if it wasn't for your passion, just how much you believed in the project. So kudos to you and Dr. Javid. And, you know, when Dr. Javid joined, it just catapulted this process to a whole different level.
Yes.
And,
Thank you.
you know, as of now, I would say that I don't know of anybody in Kentucky who has the kind of volume that we do. I actually get more AVS requests from Norton doctors than from our own, you know, doctors here. And it's a testament to what, you know, what you guys have really established here. I mean, just to cut it short, our patients, the Louisville community is really lucky to have you both advocating for them. So before I go on further, so my portion of the talk will be very technical. I apologize. I even, you know, try to use AI to make this more exciting, but I'm sorry. He flatly denied and said no. So you got this and you have to deal with it. But this will be a very technical presentation, I'll briefly review anatomy relevant to AVS, and then we'll try to understand catheter selection. And I spoke to Dr. Krish about this, and she's like, well, it's medicine, people. Let's cut down on the catheter selection. I'm like, well, we got it. So we would just briefly talk about what I use to get into the right and the left adrenal veins. We'll compare some selectivity techniques, and we'll discuss some potential pitfalls and some future goals. So again, Dr. Krish has already talked about this, so just to not be redundant, it is the gold standard, right? And it helps us to differentiate unilateral versus bilateral disease so we can guide sort of surgical approaches. The reason why this is important is because of this number. I mean, the discordance, where's my mouse? There it is. Yes. So 30 to 50% discordance between imaging findings and what our sampling results show. That is almost as close as 1 in 2 patients. That's not doable, right? So we come in because if we have imaging findings that support that there's a right-sided nodule, we have to prove that the nodule is either the right or the left. Where is the spurious hormonal production coming from? And more often than not, up to 50% of the time, it's discordant. So it's very important that we actually rely heavily on successful sampling. This is a very basic table. 2 catheters, sampling syringes, and everything is done under sterile conditions. Once I get the call and the patient is approved for the procedure, we go through moderate sedation. We do cosyntropin infusion, and I'll discuss that a little bit further. But Dr. Krish, I limited it to just 2 catheters. But if you thought radiologists were greedy because we always keep asking for more images, you're like, well, how many catheters does it take to get into one vein on the right and one vein on the left? It does take a lot, but I try to just limit it to 2 catheters. And this one shaped here is called a Cobra 2 catheter. This is called a Simmons 2 catheter. So far, they've both worked really well for me, and that's pretty much what I stick to. The reason why this process is so unnerving and so difficult is really truly because of the right adrenal vein. The right adrenal vein is short, it's small. We're talking 1 to 3 millimeters, just a little bigger than my catheter that I use, which is a 5 French cath. And it also drains at a very acute angle into the IVC. So you can imagine, I am trying to lodge a catheter into this tiny vein and aspirate 10 cc, another person who was greedy are the lab people, the path people, nothing is ever good for them. I'm like, why do I have to pull 10 cc? Can I not just give them a cc? So this catheter has to stay in there. Sometimes it's a 75 centimeter catheter. Sometimes it's a 100 centimeter catheter. And I've got to aspirate as much as 10 cc for them to have enough samples to work with. And you can imagine, as short as it is, if I wedge it in too deeply, I run the risk of potentially rupturing the vessel, right? Or thrombosing it. And if I don't wedge it in and anchor it properly, we run the risk of actually having the catheter fall out. So it's very important to just get it just right so we can actually get the samples we need to do the procedure. What I've actually started doing is I modify the tip of the catheter. So I will use, this is a 21 gauge micropuncture needle. I will create a small side hole along the very aspect of the catheter, just right next to the end hole of the catheter, so that when I seat the catheter inside the vein, the egress of the venous blood coming out from the adrenal vein will allow me to slowly sample the blood without, number one, rupturing the catheter or thrombosing my catheter. And we've had some pretty good results. High volume centers like Dr. Krish is talking about with Mayo, their success of sampling the right side, I thought it would be a little higher, frankly, but it's around 80 to 95%, which shows you how difficult this really is. And these places are doing up to greater than 40 cases a year. Some lower volume centers that do 10 to 20 per year, results are actually pretty not good, 50 to 70%, which again, shows you how difficult this can be. And again, if you're doing your first 20 to 50 cases, your sampling results are pretty bad. That means every other patient that shows up, you're going to have an unsuccessful sampling process. So those are not great results, but I think we've done pretty well here. So again, I do a dual access into the groin with my sheets. There's moderate sedation. We initially did concentropin boluses just to ramp up, hormonal secretion, glandular hormonal secretion. But again, Dr. Krish was like, well, Mayo is trying this continuous thing, and I think they're getting really good results. So why don't we adjust our protocol? And she's done an extraordinary job with just building in new steps to augment our protocol and improve our sampling results. So we tried the concentropin infusion, and it's been a game changer really, because it ramps up hormonal production from the gland, and it allows us, even in cases where you're sort of semi-wedged into the adrenal vein, but you're not truly there, it allows you, it kind of saves you a little bit so you can actually get adequate sampling results. So that is really, really important that we've switched to the continuous ACTH infusion. So this is the basic premise of the procedure. So my first thing after I get access is I do a cablegram, which is the one on that side. You ask me, what does it really do for me? Nothing. It just is for planning purposes purely. And the next thing I do is I cannulate the right renal vein, and I do a right renal venogram. If you're thinking this looks a little bit odd, yes, it does. Usually a right renal venogram should just stain the renal vein, and nothing should go down anywhere else. If you're asking what this is a big ovarian vein on the left, and this is a patient that Dr. Javid and I shared. So on my my left renal venogram, I saw this. This is how it's supposed to look. So this is an incompetent left ovarian vein that we ended up treating for this patient. So sometimes you do find, results like that. But once I do my renal vein on the left and I clear it, I will cannulate my adrenal vein on the left side. Usually it's on the superior margin of the left renal vein, and it comes off just at the anterior 1/3 of the vein. The adrenal vein does share a common origin with the inferior phrenic vein. So you can see that it's almost like two staining patterns there. This one goes to the adrenal and that goes to the inferior phrenic vein. One thing I've noticed is if you wedge it in too deeply, you actually miss the adrenal vein and you will not have successful sampling results. But if you leave it just right there, right at the origin of where the vein is coming in, it allows you to have better sampling results. And obviously this is how a cannulated right adrenal vein should look like. And usually there's a downward draining vein, which is called an emissary vein, that also helps you clinch the diagnosis that you're actually in the right renal vein. And once the cortisol results are confirmed, that gives you the green light to go ahead. So potential pitfalls to right adrenal cannulation. This is something that I wish they actually mentioned this a little bit more, but per our data, this is very, very, very common. So there's some great mimickers for adrenal veins. We have, accessory hepatic veins, accessory renal veins sometimes. But what I'm seeing more often than not is accessory hepatic veins that masquerade as adrenal veins. And you have to be very, very careful. So this in particular was an accessory hepatic vein that had the adrenal vein coming off of it. So I had to actually wedge it in deeper to get a proper sampling result. And this is another one. So you see the accessory hepatic vein up there. And there's another one that shows the accessory hepatic vein with the adrenal vein, the right adrenal vein coming off of it for sampling. So it can make it a little bit difficult, right? This is a binatal cannulation venography that I did. This is one of actually two different patients. Both of them are from Dr. Javid. And the reason why I actually put them up is because I challenge any of you to go on the internet and find a glandular staining pattern that looks better than this. You're not going to find it. And this is because of us, Dr. Javid. This is beautiful. So I just put it up because it just looks so beautiful, right? Look at this. Look at this glandular staining pattern. So we're getting into these veins and we're actually showing how beautiful it looks. But one thing I wanted to point out, the left may be easy, but it's not always that easy, right? Sometimes if the vein comes off directly off the left renal vein and it doesn't share a common trunk, you can miss it. So this is one that actually came directly off. It doesn't share any common trunk. It's just the vein is just coming off by itself. There's no shared drainage with the inferior phrenic vein. This one shares the drainage, so you can see how it looks, right? This is another one that just came directly off. But if you sample from here, you're not going to get it. You have to actually go a little deeper into the vein to actually cannulate it and get good sampling results. So we're going back to our patient that Dr. Krish talked about earlier. So we get our cross-sectional images, and two things are going to happen, right? We're going to find an adrenal adenoma, but if it's a lipid-rich adrenal adenoma, we can just move on to the next steps. And that's a very easy one. On a non-contrasted image, you're going to look at the Hounsfield units for a lipid-rich adenoma, and it's going to be less than 10 Hounsfield units. Slam dunk, no questions asked, you're good. In this particular patient, the non-contrasted image, look at the Hounsfield units, it's way up there. So it gives you pause for concern. You're like, wait, is this something else? Because this could be an adrenal cortical carcinoma, this could be FEAL, this could be metastasis, this could be an adrenal lymphoma. You don't know. So that's why the adrenal protocol CT in cases like this is very, very important. In benign lipid poor adenomas, which this one was, the capillary structure is still intact. So there's excellent drainage. They're not going to hold on to contrast. However, if it's METS, if it's adrenal cortical carcinoma, if it's FEAL, if it's lymphoma, they hold on to contrast. So there's very delayed washout. So we do an adrenal protocol CT looking at the washout patterns for these. And in this patient, we have an absolute washout and a relative washout. We actually trust the absolute washout a little bit better because that actually takes into context the contrast, like the intrinsic Hounsfield unit of the adrenal adenoma without any contrast on board. So we trust that a little bit better. And in this patient, it was way above 60, which was 74%. So it gave us strong sort of reliability that this is an adrenal adenoma, it's just a lipid poor adrenal adenoma, right? So the next phase was just to sample. We do our venogram, we do our left renal venogram, we get into our left adrenal vein, we sample it. It shares a common trunk with the inferior phrenic, which is expected, one of the more common variants of this, anatomy. And it was successful sampling on the left. On the right, however, we got into a vessel, injected it, beautiful delta pattern. I'm like, oh, great, we're done. So when I did the slow, deliberate injection, you can see that it's filling this vessel up here. That is an accessory hepatic vein. So if I had sampled this, it would not have been appropriate. So we had to go searching for the adrenal vein. And we finally found it. This was the adrenal vein. You can see that it's beautiful staining pattern. We sampled that. I was a little bit not very confident in my anchor because the patient's body habit. So there was a lot of respiratory variation, and I was worried that my catheter was not holding very well into the adrenal vein. So I actually took 2 samples off of the right adrenal vein, and I do that sometimes because if I don't, I'm going to wait 40 minutes for the lab results to come back and say, well, you don't have enough cortisol to clinch the diagnosis, so you have to go back and repeat it. And by then, sometimes the vein is thrombosed, the catheter is dislodged, and we have to do the whole process entirely again. So if I'm not confident that I'm well seated in the vein, I will take 2 samples. And luckily, both samples came back. Dr. Javid is going to talk more about this. So what we do is we take 2 samples. We send one to the lab for the cortisol measurements to tell us that, hey, you have successfully cannulated the adrenal veins bilaterally, and we're good. We're just going to wait on the aldosterone results that we sent out to Quest. So this is what we act on. But for me, this is all I see that day. And in this patient, the peripheral cortisol was expected, low. The right adrenal venous cortisol was perfect. The A sample was over 1,000. The B sample was 800, which is perfect. We want anything, because we have this cosentropin infusion, we want anything that is 5 times greater than the peripheral cortisol levels. Once we saw this was great. The left was perfect. We had our answer to wait on the aldosterone so we can decide on which side had the spurious production of hormone so we can act on it surgically. But that's pretty much all I have. So future goals, if we can find better ways to sort of optimize our results. There are times where if we have equivocal findings, we would like to bring the patient back and maybe just do repeat tests. Most places, I was talking to Dr. Krish yesterday about this, most places will, sample the adrenal veins without any ACTH analog infusion on board, and then compare it right afterwards to the ACTH infusion and just see how that varies. because a lot of times we're ramping up hormonal production globally, right? But sometimes that can mask or unmask other inherent, differences in both sides, and maybe just seeing how they are with and without might give us some more answers. And research. I'm sitting back where we're working on this presentation, and I look back to where we were and how things have evolved. And we've done so many cases now. It's ripe for research, and I feel guilty, talking about this, because you've asked me so many times to put things together. So it would be great if any of you are interested, we can look back on our data, see what we're doing, how our concordance and discordance rates like. Is it really truly close to that 30 to 50% that is reported in the studies, or is it even less? I personally feel that it might be a little bit on the lesser side, but again, that's why we do this. Some of our variant anatomy with hepatic venous drainage sharing with adrenal veins. How common is that? Is that similar to all the reported studies out there? So these will all be great to find out. And that's all I have. Thank you.
Thank you so much. I will just spend a few minutes discussing some of the perioperative aspects of this care, but I will want to give some time back to Dr. Krishnasamy. But needless to say, you can just see how talented your team is here. It just speaks to testifies to the commitment and talent of Dr. Krishnasamy and Dr. Baah as to how well our patients do. They have really great, successful outcomes. And you've just got such expertise here, not only them, but also Dr. Jortani in chemistry, and our pathology colleagues make this, just an excellent team. So let's go back and look at what we do in surgery for these patients. As we mentioned, we usually see just lipid-rich adenomas in primary aldosteronism, but it's not necessarily the case like in this patient we're discussing today. But often they are very small tumors. So the reason why we need Dr. Baah's skills is because even though we might see an adenoma on one side, that doesn't necessarily mean that that's the side that the disease is coming from. It might very well be that your scan does not show a sub-centimeter nodule on the contralateral side, hence, the discordant results with AVS versus your imaging. And that's why we send all our patients to Dr. Baah to confirm whether indeed it is that ipsilateral adenoma that's the problem, or whether or not you even have unilateral versus bilateral disease. Because in the case of bilateral hyperplasia, this is an indication not to do surgery. So we heard about the great skill required to do the AVS, and the end result is that we would like to see the aldosterone over cortisol ratio being more than 4:1 ratio on the side that we're going to remove. And again, we talked about, giving ACTH, and these were the results we saw earlier. Now, just to reiterate that it's very hard to get into these veins, and so we have a selectivity index where we monitor whether, in fact, those samples were indeed taken from the right and left adrenal veins compared to the midline, so the IVC in this case. So the selectivity index measures the ratio of cortisol between the labeled left and right adrenal veins versus the IVC cortisol level. And if this is more than 4, that indicates good catheter placement, as you see as excellent levels here. And then we lateralize. So then we look at the aldosterone over cortisol ratio and compare the average result of the right side ratio versus the left side ratio. And if that is more than 4, that indicates unilateral disease. So 4:1 ratio. Here we've got much higher than that, right side dominant. And when right side is dominant, the left side is suppressed. So this is an excellent result, and it gives us a good feeling that we go ahead with right-sided adrenalectomy, which is by far the best treatment for any unilateral primary hyperaldosterone patient who is a surgical candidate. Be aware, you do need to interpret those imaging findings and make sure that you do have something that's benign or likely benign, because if it's not, that may alter how we do the surgery. For example, if you are considering a cancer, adrenal cancer at least, it might be that minimally invasive techniques are not appropriate. And also be aware, you do need to know your functional workup, because often it's the case that you have more than one hormonal secretion, in which case you need to decide whether there's a co-secreting ipsilateral nodule, or if you've got bilateral secreting nodules of different hormones, and you need to know how to manage that. We mentioned the benign imaging characteristics, so you know whether you're dealing with a benign adenoma or not. And these are the surgical techniques that are available. You can do open technique, or you can do minimally invasive laparoscopic, either from the anterior or posterior approach, which is a slightly newer technique than the open transabdominal one. And either of these can be robot assisted as well. I won't go through all the anatomy, but needless to say, the adrenals are a very difficult spot, especially if you are going in a transabdominal approach, because they sit right at the back of the abdomen. Their retroperitoneal sit right above the kidneys. And if you go in from the front, there's multiple organs in the way that are different on the left versus the right. So if you can get in from the back approach, if the anatomy of the patient is good enough to get in from the back, and by that I mean there's not too much adiposity in the tissue right at the back. You have to be able to feel the tip of the 12th rib in order to place your ports from the back. And if that's the case, then all these other organs that are in the front, such as the pancreas, the spleen, the bowel, the stomach, the colon, are on the right, the liver, are out of the way because you're going back. But again, you do need to examine the patient and make sure that that is appropriate, because what happens is the patient from the posterior approach is placed in a prone position, and the ports are placed kind of blindly, actually, with just palpation of those ribs. So this, patient, for example, was someone I did and managed to do a retroperitoneal approach where you just have one 10mm incision and two 5mm incisions, and you can get, fairly large, even up to like 7-8 centimeter nodules out through the back that way. Needless to say, our patient, who had a BMI of 48, was not appropriate for that approach. She also had an extremely large liver, which was up to 29 centimeters. So this was difficult any way you look at it. And I remember telling Dr. Krishnasamy, even from the transabdominal approach, what you have to do is retract the liver back. And in this patient, it was still flopping over. So it's very difficult to get it out of the way. And we mentioned earlier that you can have liver enlargement and fibrosis as a result of primary hyperaldosteronism. So we won't go through the entire video, but Dr. Moulton Waltz really popularized this retroperitoneal adrenalectomy some years ago. And I just wanted to show you that it's a very tight space. It's not like a transabdominal approach where you can just see everything. If you want to get in by hand, something bleeds quickly, you can just go ahead and do that. It's a very tight space. It doesn't actually exist until we put gas in. We're kind of creating the space as we go in. But one advantage is you can increase the pressure that you have from the back, which gives you a little bit more space, whereas from the front you can't go higher than 15 millimeters of mercury. So when we look at the patient here, here's the prone position, and when you see them putting in the ports, you can see that it's by a feel. So they are actually putting in the ports from just feeling the tip of the 12th rib, and then making sure that they can feel that, and then putting your finger in before you then put your other ports in, again by feel. So it's not like a transabdominal approach where you see everything as you go in. You're not actually seeing your ports until you've put your camera in afterwards. So some people don't like it because of that. And also, as I said, it's a bit harder to convert it to an open procedure. I've never had to do that. I don't know if Dr. Taylor has, but it it's possible that if you had an emergency and you had to open, that 12th rib is in the way, the kidney is up here and the adrenal is way up high. So even to get to that, even if you did open from the back, it's possible you would have to resect that 12th rib, which you don't need, but it can be painful. And again, it's just not something that's expected. So you've got to be pretty confident that you can get your anatomical landmarks under palpation and get to that 12th, that adrenal way up here. One issue can be that if a patient has quite a lot of adiposity at the back, the ports actually hit, the patient, and you can't actually retract enough to get as far as you need to get to the adrenal. But if you can get it this way, it's a nice technique because you're not putting gas into the transabdominal space, which often causes a lot of bloating, perhaps an ileus. These patients often go home either same day or usually the next day because we're trying to do some labs on them to make sure that everything is settled down. So, you dissect, you find the pole of the kidney. Often there's a lot of Geroda's fascia even from the back. So you might or might not see the kidney. You may or may not even see the adrenal. It's often surrounded by a lot of fat, but you don't need to, as long as you know that you've resected everything above that kidney and the adrenal will be in there. In the right side, this is the IVC. So we're working very close to the inferior vena cava. You've just got to be sure that you have good visualization of that. And the adrenal vein, which is the main one that we clip, is way up high. So even though you've got the IVC, you've got to do a lot more dissection before you actually get to the adrenal vein, which is even higher up. So not much anatomy from the back. You've got the spinal muscle, the liver in front of your peritoneum, the upper pole of your kidney, the IVC. You work up towards your adrenal vein, clip it and take it out. Simple as that. So we did this from the transabdominal approach. Needless to say, pathology did confirm a benign adenoma, and it's great that our pathology colleagues do put in the modified Weiss criteria scoring system that confirms that it is not malignant or has a more benign behavior. It's important to mention that postoperative management is really important. You've got to stop the potassium and potassium sparing medications because it is now resolved even from day one post-op. However, blood pressure may still be high, and it's good to continue to monitor that, as well as your BNP postoperatively. Some patients do stay on antihypertensives because they might have coexisting essential hypertension. And one thing I'll mention as an alternative that's coming around is radiofrequency ablation for non-surgical candidates. It's not that minimally invasive because these patients still need general anesthesia. And they can get hypertensive crisis because you're really burning the medulla as well. And so they often need preoperative output blockade. In the small amount of series that are out there, they found that you can normalize your biochemistry, but you will often have persistent hypertension. I will pass it back to you.
Thank you so much. I have a minute left, so I'm going to skip through the slides and get to the final slide because I did want to compare adrenalectomy versus, the outcomes and the cardiovascular outcomes. In those perfect surgical candidates is always much better when you have a great radiographer and a great surgeon, and we have all that here at University of Louisville, so I'm very happy for that, and thank you to my colleagues. So I just wanted to spend half a minute on going over the medications because majority of the patients may not be fitting the criteria for this, especially those that don't have resistant hypertension or don't have clear ratios. We end up doing mineralocorticoid antagonists, MRAs, and epithelial sodium channel drugs such as apleneron or triamterene. And many times, more recently, there's been studies looking at finerenone, the newer NSAID non-steroidal selective MRA. That's the FAIRY study that's ongoing, which has, we're looking forward to the results next year. And there are more and more drugs. The aldosynthase pathway, actually, Dr. Taylor's here, our other endocrine surgeon, and he had sort of discussed this at one of our tumor board. There are 2 studies in New England Journal of Medicine, but not looking in primary hyperaldo, only in resistant hypertension. In fact, we discussed that also. And there are a few other sort of drugs and everything, and the outcome is minimizing cardiovascular complications, renal arrhythmias, strokes, and so on. So I will skip to the rest of it and just say that 3 to 14% of people with hypertension who are screened into primary care and 22% attending referral centers do have primary hyperaldo. If biochemical tests are abnormal and no confirmatory or subtype is needed, treat with MRA. But if there's severe primary hyperaldo with hypokalemia, no confirmation is needed. And usually we pursue to localizing these tumors so that they can go on to have surgery. Functional scans that have been looked at in lieu of adrenal vein sampling have not made it to prime time yet, and so haven't the adrenal metabolomics. They're being looked into. And if they're not surgical candidates, medications are available, just like D.Phil mentioned. And I wanted to thank the wonderful team that I worked with, those who are here and also those who are online, and also Dr. Young, whom I used to send midnight emails and he would respond the next day. From Mayo Clinic, Dr. Bankers, and also Rich Arcus at Ann Arbor, University of Michigan, where Dr. Khan is from. They've all been very helpful nationally to help launch this project. So wanted to thank everyone and say I'm happy to take questions.
Thanks so much. We're over time, but there's so many questions that probably the first one that would come to the mind of many is the idea that hyperaldosteronism, the key is to use a little bit of a thiazide, which is standard therapy, and see that the potassium goes down, because it really shouldn't with low doses.
Yeah.
But that was called into question recently. I thought that it's not the best idea. It looks like we ought to be screening people kind of regardless of what's happening with the potassium.
Yes, so actually I did sort of quickly skip through that part. In the past, the way we diagnosed the 1% was, low potassium and resistant hypertension. But that's a very small group of patients. Majority of them are not hypokalemic. Yeah, if they're hypokalemic, sometimes we look for actually genetic or familial hyperaldo. That is a clue. If they get thiazide and they drop low, and they have family history of patients with young having stroke or something, they need to be screened for genetic. The 2 genes that I mentioned. Yes. Thank you.
Too bad Dr. Bob was going to ask him if he was going to patent side holes. Pretty ambitious.
Yeah, he's awesome. I took Dr. Contractor. Please make sure that he's happy and stays.
Any other questions?
There is one in the chat, Dr. Krish. It's from Dr. Levinson, and he wanted to know, can an MRA provocative test be used to simplify the diagnosis and avoid some invasive procedures?
That's a great question. Usually the previous tests that have been used apart from the captopril challenge test is also a fludrocortisone challenge test, which I've never done, so I'm not sure how that works. But I have not looked into the MRA tests. And certainly that is something we should talk more about. Yeah. Thank you.